The question, before I turn it over to the group, I wanted to start off with, can you all speak to the group here in terms of the one priority in terms of how you would recommend or advise people to, if they're looking to grow this type of medical services in their respective, I'll say, delivery settings, what would you recommend? What's the highest priority that people need to do? So with that, I'll turn it over.
Pray a lot. There we go. Pray. No, I think this really is. It requires so much on the part of physicians and other healthcare professionals, but also on the part of the hospital taking this leap of faith. I really think it does require a significant amount of prayer to bolster then your efforts going forward with meeting up with the administrators, like we had talked about earlier today.
Pray. I would agree with that. Because I think that's how you start, as I tried to express through my talk, with getting that inner conviction about what we're doing here. I mean, really, it is a calling. I meant to tell the story last night, but I'll say it now. Maybe now's a good time. When Humanae Vitae came out, everyone thought that the church was going to change its mind in terms of its teaching in the area of family planning. And it did not, and through this document, Pope Paul VI reiterated the church's constant teaching: you cannot divide love and life. The Catholic Medical Association at the time, as I understand it, I heard this from Dr. Peter Morrow a couple of years back at the National CMA conference, had 10,000 members at the time that the document came out. And there was a mass exodus and rebellion because the church did not change its teaching and its stance on birth control. From 10,000, the numbers went down to 200 or 300. This is a mass exodus. Now I think there's like between 2,000 and 2,500 members in the country. And they were built, I mean, the current day Catholic Medical Association is built on this original 200-300. It's the only annual medical conference I go to where there's 24/7 adoration throughout the conference, and it's attended throughout the entire conference. It is really amazing. So it really is a calling to be countercultural. I think you have to have this inner conviction that we're offering good care. We're not offering suboptimal medicine for patients. We don't have to be apologetic about it. If it's true, it should work and work well, and I think it has to start there, and then that just drives all of your conversations and everything. So
I agree with that. I think too we're at a point now where the big Catholic institutions and hospital centers need to realize they're sitting on a gold mine. You know, you have a whole group of patients out there, Catholic or otherwise, who really want true help in this area, and you're talking about patients who are going to be with you forever. That's largely because we're in the minority and there aren't so many of us, so then you just tend to have people stick with you. But I think Dr. Putoff, said, listen, I have 60-something plus more percent coming out of this area. We're down in Houston, we have patients coming from Latin America, South America, all over really, and it's quite remarkable. It has nothing to do with any of my jokes. Trust me, it doesn't. It's because of the work and because they seek out because they want healing in these areas. And so I think it's really time for us to realize what we're sitting on and how we can really capitalize that, and not only helping patients but also growing practices that will take off and really be successful in that area from a kind of a business end of things. And so that's the only thing I would add.
Kind of mulling over, there's always a long list of wants, wishes, to-dos, but thinking about our healthcare system and the support that we have, it kind of boils down to two things: having your leaders, your administration, have that support for you, and then having not necessarily a large volume, but a couple of key physicians or providers that are really passionate about it, that can go and display that to fellow physicians and providers within the healthcare system, because from there it starts to blossom. And that's where I think it comes down to. It can't just be from the leaders or the administration kind of saying, do this, and it doesn't work if you don't have that support as a physician coming into the healthcare system, because it can be a tough world. But if you have a small amount in both worlds, they're teaming up together, it's definitely going to be a success.
Sorry, one last, I guess, practical thing is because I was talking with somebody at the break, and they made a comment like that. Sadly, money talks, or money is what makes the world go round, which is kind of true. So I think you do have to have a viable business plan, which can be done and has been done. So to learn from other practices who have been built up, like Dr. Putoff's practice and so on, where they have shown the numbers that this is a viable option. It brings in money, it brings in patients to the practice and to the network. That's very helpful.
Excellent. Thank you. We'll start over here and then come over here and back.
So thank you very much for all being here. This has been great. I'm Lisa Gilbert from Wichita, Kansas. And a couple of questions, and you guys actually just kind of touched on it right at the end there, so this may be a little bit redundant, but in terms of how to win buy-in among other physicians who may be on the fence or who are outright kind of objecting to this sort of on principle, that it's not ACOG guidelines or something like that. Especially for me as a family physician, often I'm not able to speak with any sort of authority in a way that's accepted by our fellow OBGYNs. Any thoughts to that as to how that can be navigated? And the second question is, how do I advocate to bring administration together with the diocese? Because there can be a sense of the diocese saying, well, this is something that the hospital should take care of, and then the hospital saying, well, this is natural family planning. This is something that the diocese should do because it's a Catholic thing. Even at Catholic healthcare institutions, there can be a little bit of well, that's somebody else's turf, and we're not going to really go there. Do you have any thoughts on either of those and how we can intervene to bring people together rather than to siphon into our separate roles?
I think to your first question about how to reach those more stubborn other physicians, I think results speak the loudest. And if you have patients who are struggling with infertility or struggling with PMS symptoms or struggling with endometriosis, and you provide effective treatments other than just the standard birth control pill, and those patients then might happen to run into these other physicians and then be a witness for your type of practice, I think that speaks volumes. And like I said, my talk is that whenever I have any of those patients who have contact with other physicians, I use that as an opportunity, whether that physician referred the patient to our practice or not, to reach out and say, this is what we're providing, this is why we're providing it, this is what we expect the outcome to be, and we look forward to sending her back to you when she's pregnant. And then when they get that patient 3 or 4 months later and they are pregnant, they sort of have to scratch their heads and say, although I didn't really buy into what Dr. Putoff is doing, it seems to be working because the patients are coming back pregnant. On the second point that you made about the diocesan versus the hospital situation with NFP, I think Diane Daly actually would be an awesome resource for you, because she works both with the diocese, but she also works with the Office of Natural Family Planning, but she also has worked integrally with Mercy Hospital in establishing the Fertility Care Center, so you may find her afterwards.
I am pro-choice. In that, I think it's really effective and true to say we are about offering options to patients. I mean, in the world of fertility, this town and any town does not need another IVF center, right? I mean, it's just saturated with IVF centers. But if you say we can offer an option and an alternative that works, that patients are seeking, this is very business savvy and works. And if you have a town with a Catholic population, or just in general, there are so many patients who are looking for organic, drug-free options for women's health, and then options for IVF for fertility. You know, that aspect of just offering an option, which may not be for everybody, but a viable option in a market that doesn't have it, I think makes business sense.
That's a really good question. There's two of them in there. One of them is how do you relate with the other folks who are doing things differently? And number one, it's just the olive branch. You know, in a way, you kind of have to get out there and be an apostle and work with these folks. And it's amazing how you might change minds, you know, just by doing it. And I tell folks, whether it's OBGYN or emergency room care, I mean, this kind of stuff does pervade other areas of medicine. You know, be the best doctor you can. And if you are, then other doctors are going to respect you for what you do. They don't have to understand it or agree with it. I'm in an OBGYN department in Houston where I'm definitely the minority, but not being confrontational, but also doing what you believe is right and how you do it. And they might not come in your, you know, invite you to lunch to figure out what you're doing. They might, that'd be great, but they'll appreciate that you're a good doctor and that you take good care of your patients. And if you do those two things, I've found that the medical community respect what you're doing. The second question you had was, what do you do about ACOG and all these other things that say you got to do A, B, and C first, and if you're not, you're outside the standard of care? That's a trickier question. And you're absolutely right, that's a hard one to navigate. The good news is a lot of the research and what we do is there, and it's just basic gynecologic health. And so what I have to document quite commonly for my patients is they decline the birth control pill. They don't want that as an option, and they seek other, you know, forms of getting this done. And you just have to go about, you know, documenting those things, and that's really important. You know, and I get what you're saying. There's things out there, there's standards, and you don't want to go against those and have somebody come back and saying you're saying that, you know, doing something outside of the standard of care. But the research is there. Everything we talked about today is basic gynecology and works quite well. And if you do that, you'll be fine in terms of the medical protocols.
Dr. Dwayne.
So many of us have spoken about how the pill is commonly used to quote unquote treat so many conditions, and it really simply suppresses the cycle. And you pointed out, Dr. Hildreth, so beautifully how the woman's cycle has these normal hormonal changes and fluctuations. And my question is for so long we mock women for that. We're like, oh, you must be getting your period and you're all depressed, or, you know, we mock them because of the normal changes that happen with their cycle. So my question is are any of you guys familiar with research or science specifically that speaks to the differences that a woman experiences at different points in her cycle? I mean, I've heard about, you know, when her estrogen is rising, her energy level goes up, and, you know, she's much more comfortable in social situations. And I understand clearly, like, when women go through menopause and they no longer have estrogen, you know, they're a much higher risk for heart disease and heart attacks. And so is there any research talking about the different phases of the female cycle and how that affects not only her physical health, but also her emotional health? Because when we see, or when women are being given the pill to shut it down, we're losing the potential benefits, you know, that women may experience because of where they may be in their cycle. So, I mean, I've heard lots from anecdotal experience, you know, from my own and from friends and patients, but I'm curious if there's any research to that.
I think the question, it was a great question, I think the question was, on the pill, are we suppressing good things? Is that the idea?
Well, yes, but even often, what are those good things?
Yeah.
Do you have anything documented that's saying women who are not taking the pill are better at this, this, and this? You know, we talk about how, you know, the pill can affect attraction and can affect, we were talking about facial recognition, but is there any documented, probably in the social sciences literature, of the positive benefits of the female hormonal cycle?
Having normal hormonal function, and what are the benefits of that? Well, you know, I think it largely comes down to the side effects of the pill. You know, there are a great number of patients who come in, and I don't know if the other doctors would echo this, actually come to me saying, I don't know what you do, but I don't want to be on the pill because I felt horrible on it. And I think there's a little bit of, maybe I don't want to tell my mom or my sisters or my friends that the pill doesn't agree with me because it's so prevalent. You know, I think there's a little bit in terms of endometriosis and pain with cycles to not want to cry wolf or say that it's not for me. And so, but there are side effects associated with it. I know that. There's also negative aspects. For example, women in cervical mucus receptors are significantly decreased to the point where they cannot replace them quick enough when they're on the birth control pill. There's a higher level of breast cancer. There was the recent nurses study that came out within the last year. There's increase in hormone dysfunction or depression associated with certain ones. There's blood clot issues. And so in terms of looking at the cycle and feeling euphoric or different things like that, or pheromones or things, I haven't seen much in that area in terms of normal cyclical function, because so much focuses on dysfunction and then the side effects of the pill. So I think the biggest bang for your buck would be looking at the side effects that women experience by being on it. In a way, that artificial substitute for their normal function is speaking loudly.
I can't say any specific research, but I do see the effect of women coming to me as far as saying that they can't think clearly. They're having trouble sleeping. They lose that sense of themselves, and then I start a PMS protocol such as HCG because of their hormone levels, and it completely resolves. And they come to me saying, wow, I can process things better, I can think clearer. It wasn't just depression or anxiety, but it was actually that ability to process and think. So kind of looking at that'd be a great idea on research to say, you know, women that have an underlying hormone abnormality that may not be really obvious except in some of these different concerns, but when that gets to be a normal rate, what level of normalness is there, you know, for a woman in their emotional sense. So
Just very quickly, I don't know if it was mentioned in some other talk or not, but you mentioned very briefly there that it affects attractiveness. Was that talked about? Or did people catch that? There have been multiple well-designed studies done by groups, not NAPRO physicians, but by other groups, that have shown that women on the pill are less attractive to men. It changes the histocompatibility or whatever, or the pheromones or something. I mean, when I talk to patients, I say, the way the birth control pill works is it's kind of like inducing a chemical pregnancy. It's flooding the system with hormones so it thinks it's already pregnant so you don't ovulate. In that, way of thinking about it, the common side effects are things like symptoms of pregnancy: nausea, bloating, weight gain, breast tenderness, mood changes, irritability, chocolate cravings. Not every woman loves feeling to be pregnant. And then serious but rare but significant would be blood clots and liver issues. But I mean, the whole push for this pill is to have this sexual freedom or reproductive equivalence to men. But what's actually happening is they can be making themselves less attractive to men. This to me is mind-blowing. Talk about good ethics is good medicine. That is unbelievable.
Well, I wanted to take advantage of the microphone to make a shameless plug for the Catholic Medical Association. One of our members, Kathleen Birchelman, has started something called My Catholic Doctor. It's an online way of getting to specialty physicians, and it is particularly applicable for NFP because those of us who are in rural practices, we don't have, there's not very many NFP providers as far as I'm concerned. Here, there's a lots. And here you guys are thick, back where I'm at, not so much. And so having an online NFP person to read the charts for us that are not skilled in it is really helpful. So anybody that's an NFP provider would be willing to do that online and get paid for it might sign up at our booth at the Catholic Medical Association. And Kathleen can talk you through it, how this is going to work. But my question to the group, one is, Dr. Hilgers, I have to applaud your dad about being stubborn old guy. What I mean by that is he was, of all of the methods, I would in my office teach symptothermal method, and I felt comfortable doing that to couples that wanted to, and the Creighton method came up a few times, and I said, well, I'm not a provider for that, and I talked. And for me to become a provider for Creighton, I had to spend a whole dang week in Omaha, and who wants to do that? And I was one of the people that refused your invitation. So out of pride, I wouldn't do it. And but because he was stubborn and insistent that the week was spent, you guys have tremendous data, and I have to applaud your dad for that. I mean, that is very much a gift for that. Two specific questions. One is how easy, and I was talking to Patrick about this, how easy is it to teach these surgical techniques to other interested surgeons that are their regular OBGYNs that might want to do this and become trained in endometriosis surgery? And then second, on a practical matter, for my patients that I have caused a blood clot in the past when I gave them birth control pills, or I gave them Depo-Provera, and now they've had a blood clot history and there are no hormones, what do you guys do when their charting reveals that they need some exogenous estrogen or exogenous progesterones in those cycles and those deficiencies when they've already had a blood clot in maybe the distant past? Thanks.
I'll just answer the first question briefly. So I decided early on that I can't be like Dr. Hilgers, Dr. Tom Hilgers, and do it all. And I mean, there was a time when he did everything. He was doing NAPRO, doing the research, doing the teaching and the education, delivering babies. I could not do all that. And you know, some of the pioneers in the beginning, like Dr. Hilgers, Dr. Dixon, and so on, all did that. I decided for me, I cannot be up all night delivering babies and still try to be good at surgery or have the mental space to try to do some research or things. So I decided to focus on endometriosis first, and then fertility as well. But in the area of endometriosis, there are people who say that endometriosis should be treated only by centers of excellence for endometriosis. Again, in the difficult stages or the difficult or the advanced stages of endometriosis, those cases can be very difficult. And in a lot of places where there's not somebody who specializes in endometriosis, it's oftentimes the oncologists or the cancer surgeons who treat those cases, just to make the point that it can be that kind of level of surgery. The problem with cancer doctors is they're not very good at preserving fertility. They just start taking out things. So it does take a team. Volume does matter. That's been shown in many different procedures, especially complicated procedures, but also in endometriosis, that volume does matter. So it is hard to, I think, for anyone to be good at everything. So in the area of endometriosis, I do think it helps to focus on that and specialize in that.
And how about the hormones in ladies with otherwise contraindications?
I'm not familiar with any literature that would say that progesterone alone would increase a woman's risk for DVT or blood clot. So I don't have any reservation in prescribing cooperative progesterone support for those types of patients. Probably would stay away from the estrogens. Also in post-peak HCG, you're providing them with endogenous progesterone and estrogen that they're creating from their ovaries as opposed to exogenous and synthetic hormones. So I still don't see an issue with that, especially since it's just a brief, 10 to 12 day window.
Good afternoon. Lisa Jersky from Chicago, Illinois. I have a few questions that are all unrelated, so bear with me. I had my pen at the ready, as you said. All right, so
A+.
First question. Dr. Potoff, you had talked about demonstrating value, and you had mentioned some statistics with respect to your draw radius. Could you go back and review a couple of those again, specifically the fact that this is different from your average OBGYN? You mentioned that only a certain percentage come from the Metroplex. I'm assuming that would be probably translatable to other large metropolitan areas, perhaps like Chicago, for example, and that you're demonstrating that you're drawing patients from outside the local area, as well as local patients that are coming from outside your specific hospital system. Could you please review those numbers again?
Sure. So in my practice, we have 65 of our patients are coming from outside Mercy, which means they've never been a patient of Mercy, whether it's family practice or dermatology or OBGYN. So those are all new to the system. And as the Mercy upper-ups would say, those are hopefully going to be converted into lifetime consumers of healthcare at Mercy. Mm-hmm. Sorry, Slew. And actually, I would make the argument that once their initial contact is with a physician's office, that actually provides really good wholesome, complete, comprehensive care, that gives them a very good impression of the hospital. The hope is that others would provide similar care. I would say about 95% of our patients come within a 200-mile radius, so there's only about a 5% of our patients who are coming from outside a 200-mile radius. But even those patients who are coming from 3 or 4 hours, those are patients who generally wouldn't have no reason to drive to St. Louis for a regular annual visit with their OBGYN or even, an ortho surgery. So they're coming because of the very specialized care that we provide. And I would say the majority of our patients who come long distance find out about our practice on Google, on YouTube, from various internet searches that they'll do. And there aren't many people who do tubal reconstructive surgeries, so they look for those specialized treatments that we provide. Does that help a little bit?
Absolutely.
Sure.
All right, second question. A couple of you had mentioned some specifics about male factor and the idea that it is important that we're able to address the male factor. Unless I'm incorrect, I was under the impression that ACOG limited an OBGYN's ability to treat men, in this country anyway. So what do you guys do individually with diagnosing or treating men, and to whom then do you refer when there are problems? Because in my experience, it's been difficult to find people who are willing to treat the male factor because it's viewed as a relatively disposable thing in the IVF world because of the availability of sperm in general.
So ACOG actually says that there are 2 conditions in which you can treat male patients. One is sexually transmitted infections. You can do co-treatment, that's expected, and that's standard of care. The second is in the treatment of infertility, it's reasonable to evaluate, not that the patient becomes an active patient of yours that you're seeing in the office every month, but as long as it's within the scope of managing for the sake of fertility. With our patients specifically, if they have low sperm counts, low motility, we will put them on supplements like antioxidants. There's a huge array of different supplements that can be used, but actually there's a Cochrane systematic review that shows that antioxidants help to improve sperm counts, motility, and morphology in a significant patient population of men with low parameters. Also, low-dose lisinopril is something else that we use to help to improve those parameters. We can provide Clomid for some patients, injectable gonadotropins. My feeling is if we go through 3 to 6 months of treatment with a patient's husband and their counts are not improving and they're still less than 2 or 3 or 4 million per cc, then that's a great time for a referral to a urologist so that they can do the comprehensive urologic evaluation with ultrasounds and blood tests and sort of the next layer of diagnostic testing and treatment.
All right, last question.
I'd like to just real quick to piggyback. That's a really good question on the male component. A lot of the treatment we do is just including them and having them in the room. And so when my patient comes in without their husband, I say, I want you to know, I know he's busy, but and oftentimes who can get to a doctor's appointment at 2:00 in the afternoon? We go out of our way to say, please, anytime he wants to come, the door's open to have you two here. And we tell them, y'all two are going to do this. We're your team. So it's very important that it's coupled centered. And I really think somebody needs to write a book on the impact of infertility on men. Because I think we focus on women, certainly because that's where most of the testing is done, and the surgery and the hormones and the injections and all those things. Like that baby with the heart on the Instagram. But it really affects men equally, but in a different way. And by including them is so important. And there's a lot of healing there. And that doesn't require a prescription or anything like a fancy test or putting your medical license on the line. But I agree with Gavin that a seminal fluid study is within the scope, and then treating that with supplements. And you'll diagnose things in varicocele, those types of things, and of course, you can refer them to a urologist if it's beyond your scope. So.
Last question. Nick, you kind of addressed this a little bit, Dr. Young, but how can we demonstrate the need for NAPRO specialization versus a general OBGYN who's qualified to perform surgery, who has the qualifications to do surgery for endometriosis, for example, or any of the other things that are surgically approachable from a fertility perspective, because without stepping on toes, without saying that, look, I'm unaware of any research that compares the NAPRO approach to the average surgical approach.
That is a good question. So, for myself, I felt called to academics. As I explained, Dr. Hildreth was the pioneer. I really feel like if you're going to change paradigms, and that's a lot of what needs to happen here, is you have to change paradigms, you have to publish and teach from publication. So looking forward to trying to be in an academic setting, I felt like I had to have a specialist or a specialty that was a little more recognized. So I did think about doing the NAPRO, the official NAPRO fellowship, but and then having had some experience or some issue with endometriosis ourselves, I went and did the fellowship for minimally invasive surgery and then extra training for endometriosis and developed that specialty. So my first real job after 2 residencies and 2 fellowships was at Duke, and I offered to them that I could help them open up the Center for Endometriosis, which was a great niche because most GYN surgeons do not want to have to deal with endometriosis, especially difficult cases. When that became not a great fit and it was obvious, then I began to look for what I would call Catholic academics with a teaching OBGYN program, and SLU I think is kind of very unique in that area, so we ended up here. And actually there was not a position open at the time, and I just kind of cold called and sent my application or my resume and said, this is my area of specialty and I can help you create this Center for Endometriosis. So that again is a nice niche and a recognizable niche to focus on endometriosis. Now, since then, we now have this restorative fertility clinic. Endometriosis is a large part of treating infertility, but not the only thing as well. And again, they're surgical and non-surgical, but for me, that was sort of the entryway into having a niche within academics.
I think the surgery is really a good question. Back in 1970 with REI, I was more focused on treating the underlying cause. And that meant surgery or hormones or those types of things. And then with the advent of IVF, we've gone away from treating the underlying cause. And with that, what we've seen in our profession is we've really gone away from any sort of surgical evaluation or treatment. And as a resident, I didn't see any endometriosis, so I didn't really know what it was. Other than, that you prescribed the pill for it if they had pain, because nobody was really operating for it. And that doesn't mean that you don't operate for it. So I think, to answer your question, if you have an interest in helping with reproductive surgery, then you certainly can do that. You can do the NAPRO fellowship, or you can just learn from others or learn on your own or become an expert in that area. I think what has happened is we've just gotten away from even going there for patients or couples. So you just don't really see it much in terms of really trying to take a fertility preserving surgical approach. Does that kind of answer your question? So I think the bigger question is, why aren't more people doing it?
Thank you all very much for the presentations. I've been blown away at the opportunity that this provides for evangelization. And I guess I have an invitation and a question in my comments right now. It's just that I'm a priest of the Diocese of Austin. I've been a priest for 2 years. We just had our priestly convocation. The National Catholic Bioethics Center came and presented on a couple of topics. The priests loved learning about them. I'm also a chaplain at St. Mary's, which is the university parish of Texas A&M University. We have 68,000 undergraduates, lots of pre-med students. Yeah. Whoop! Do we have any Aggies over here? Class of 09. So I guess the invitation is, would love to have you either in the Diocese of Austin at a priestly convocation or at the Texas A&M University speak to our students, because it also sounds like we're having a difficulty in having enough people who can provide this kind of care. that's the invitation. The question is more along the lines of, have you already had success in working with the diocese? I know that you mentioned that in your presentation. What are the ways that we can get this word out? Because I've been so blown away by the effectiveness. I mean, good ethics means good medicine. How can we, as a diocese, as priests, help you get the word out? Have you had any success in being able to do that already?
I can speak to quite a bit of success, I feel like, in our diocese, specifically in Peoria area, with the Rockford region. So I guess I came into this role and with it already being a success. I know the priests in our area are very interested in learning more about this. Of course, there's pockets of struggle that occur, but I'm really hopeful as it grows and it gains knowledge through the system that it becomes more common through it.
So when we were first considering coming to SLU, and again, I tried to explain why I applied to SLU and thought it would be a good fit. My wife is like, why are we going to St. Louis? There's already so many providers there, so many NAPRO providers, a whole network of practitioners and all of that. And again, I really felt like St. Louis University was unique in providing or being an institution for Catholic academics, especially in the area of OBGYN. But I also really felt like there could be synergy. So if you're the only NAPRO provider in the whole town and you're doing everything, then you're really just kind of surviving. I think an advantage that can happen, and I think does happen here in St. Louis, is when there are multiple providers and multiple centers even for NAPRO, you can have different areas, different niches, and then you can do things that you couldn't do if you were just trying to provide the clinical care on your own. So we do have so many other things happening in town with the diocese through what Diane Daly is doing, including things like providing a course to seminarians. So we've been involved for years with this course that is run talking about marriage and family and sexuality to the seminarians. And I think that's really where it has to start to bridge that gap and to really let future priests know about it. This is an integral part and has been for years now through the work of Diane Daly and others to have that kind of a course and teaching to our seminarians here. And just other initiatives like that, teaching younger women through the woman and daughter programs and all of that. So a lot can happen when there's multiple providers or multiple things that are happening in the same location. Also, I don't know if, before I forget here, if there's a way to... Peter Morrow is here. He's the president of the Catholic Medical Association. There is an initiative with the Catholic Medical Association called the Holy Alliance, I believe, whose purpose is to try to bridge that gap between medical professionals and priests. Did you want to mention that briefly?
Yeah, just to be clear, we do at the Catholic Medical Association have a Holy Alliance program, which is reach out to all the clergy through the one of the top certified. So it's on our website and discussion.
For those who couldn't hear, the CMA has a really great program called the Holy Alliance, in which the physicians work in tandem with the priests to ensure kind of consistency across each specialty with regard to all the questions that we've dealt with here. Great program. All right.
Hi, I'm Stephen Pallone, Sioux City Family Medicine. Mine is actually a little bit more of a personal question. I'm particularly interested in your answer, Dr. Hildress, since your father passed on such an obvious enthusiasm for this. So as the father of a 7-year-old son, what are things that I can do as a parent to share that same enthusiasm with him so that he grows up with a similar mentality?
I actually thought what he did was a little weird when I was growing up. There's 4 boys and 1 girl, and We really wished he would just take a real job like a UPS driver, something cool like airport, airplane. We had to go to these meetings at 5, 6 and hear about cervical mucus and I think the real thing, to be honest, and somebody mentioned something about your dad's stubbornness, and I think what you instill in your children is find out what they love and what God's calling them to do. And that's the most important thing. Really, truly, for whatever reason, my dad was, the Holy Spirit called him to get into this, and he would tell you that. And so, as a child watching that, it was so neat to see a parent who, was following what the good Lord was, telling him or her to do, with all the challenges that come with it, and there are a ton. But just to stay with it, and then to see the blessings that come from that you can never foresee when you're doing something that the Lord wants you to do. So that's what I would teach your son, is just to follow what you like to do and what God's calling you to do and stick with it. Because there's going to be challenges. As we all know, there's areas, in all areas of the church, this area, and that there's challenges. It's hard enough just to spread the gospel, right? But anyways, that's what I would say. And then in terms of the understanding of reproduction, and getting your son interested in that, you just lead by example. And then when those questions come up, you have that opportunity to share and teach. And it's what we're talking about today is so inherent to the human being that you're teaching things that are really just what we already know. But you're just reinforcing them because it's basic human nature and how we're made. I don't know if that answers your question.
They are watching. And if you're excited about it, that's a good start. That's why my daughter loves Notre Dame football and the Avengers. So I'll go here, Dr. Dwayne, and then we'll come back to you.
Couple comments and then a question. One, I have to admire your father for his stubbornness. I think that's the only reason why FACS has existed as long as it has, is I'm so stubborn. When the medical schools say, no, we don't want you coming in and teaching the students, I'm like, oh yeah, I'm going to keep coming back. And along those lines, to the priest that asked the question, that's one of our focuses at FACS, is getting out there and educating the students. We've trained over 85 speakers across the country, including a couple in San Antonio, to go in and talk to the medical students and the nursing students and the midwifery students and any healthcare professional students. I really see what we do as like the appetizer, to whet their appetite. I don't ever want to replicate what Dr. Hildress has done with Creighton. I think what he's done is amazing, and I want to encourage those people to get them excited to follow in his footsteps. My question actually goes back to something that you had talked about in your presentation, Dr. Young, and you talked about the seasons, how sometimes we equate the cycle to the seasons, and how you can see in some women their seasons are way off, right? And the thought that occurred to me is, it's global warming, right? It's how do we reach the other side of the equation? You can't come at this from a moral view, but we talk about all of the chemicals, all of the toxic effect of the hormones from birth control and how it's affecting our environments. And so I'm just curious, is that a way to bring in people from the other side who will never approach this and who really want to reject NFP because it's a Catholic thing? Can we reach them on that perspective, that really what we're doing, is poisoning the environment, and fertility awareness is a way to embrace, and save the planet from global warming?
That's a great idea and a great analogy or way to think about it. Again, Ricky Lake, I think, is a great example. She has no religious or ethical reason, as far as I know, to want to find an alternative to birth control. But for a lot of women like her and others, again, it's very trendy these days. Women are very uncomfortable with the idea of flooding their body with really a WHO type 1 carcinogen and feel pregnant. You're trying to prevent pregnancy by inducing chemical pregnancy. And this idea of just flooding your body with hormones is not acceptable to a lot of women. And I think that's exactly right.
I think I sense another Cosmo article of birth control as global warming. Very good.
Hi, I'm Michaela Ebert. I'm here with Ascension in St. Louis. And it was really nice hearing all of you talk about the great work that you've done to help couples achieve pregnancy when they struggle with it. The ethical and religious directives also talk about caring for the well-being of the whole person, which means caring even when we cannot cure. Would you guys be willing to talk about what structures you have in place within your own practices to continue caring for those couples who, despite their best efforts, even heroic efforts, still find themselves unable to conceive or to sustain a pregnancy?
Yeah, those are definitely difficult situations. I think part of the benefit of what we provide with the Creighton model and NAPR technology is that even in the events where couples don't achieve pregnancy, they have achieved improved health in almost all circumstances. And additionally, they've learned this method of fertility observation, monitoring their fertility. So for those patients who say, look, we've been going at this and trying this for a year and a half, we're ready to lay this down, we want to pursue other treatments or adoption, those patients are always they're encouraged to continue charting. They're also welcome to come back anytime that they have any other gynecologic issues, because we want them to know that we're there for their entire gynecologic health. On the spiritual side of things, we have great support from the Fertility Care Center primarily for infertility couples counseling that is, I believe, offered free of charge. I'm not quite sure. But we often will refer our patients who are in the difficult struggles of their infertility treatment, or sort of dealing with this as being a cross that they're going to carry for an indefinite amount of time, to seek out trained counselors, because we don't, as physicians, we don't really have that training or capacity, and I think those are better resources for those couples. So both on the medical side of things, being there to support them, but also on the sort of spiritual or emotional side of things.
So again, I always tell patients we're all in this together. My wife is the first to say, if a woman is not getting pregnant, there's a problem, there's an issue. And like in the video that you saw, women want answers. So it doesn't always happen. At best, I use the phrase, we try to set the table and then offer it up. But in the process of trying to find the problems and correcting the problems, patients often feel better. And they get answers. And that alone is is valuable, and some kind of resolution, even if pregnancy does not happen. Also, there is the option of adoption. So in the NAPRO protocol or framework, if a couple has, or a woman has 12 effective cycles, that means the anatomy's been optimized and she has 12 cycles of charting where the charts look great and the hormones are optimal, the cervical mucus score is optimal, and she's still not pregnant, which can take about 2 years. Then maybe she's completed the program, and then we talk about adoption. And adoption, I think, is not well understood. So we adopted, so I'll try to make this quick, but oftentimes adoption can be seen as the worst option. Like for the birth mother, it can seem like she has to have the baby and then give up the baby, which seems like lose-lose. When we went through the adoption process, you have to sign up on 6 hours of reading, and the reading is all about like issues of regret for the birth mother, and then issues of abandonment for the child. We had our girl that we adopted as an open adoption situation. So we met the birth mother while she was still pregnant. And our Lucy, who we adopted, has met her birth mother, and she has pictures of the birth mother in her room. The birth mother gets updates. So a lot of these issues of regret and abandonment kind of disappear. The birth mother knows that the baby is okay, and the child grows up knowing that she was placed out of love. So open adoption is really a fourth option, which can turn a lose-lose situation into a win-win situation potentially, and is not really well known about. And to adopt a child and to be chosen father and mother by another human being. Like, who would be good enough to raise your child? But to have another human being choose you to be the the mother for the child, and this birth mother has more energy than both of us combined. She could have raised the child herself, no problem, but she chose my wife and I, and I asked her when we first met over the phone, I said, if we could help you financially or otherwise to raise your own child, would you want that? And she said no. And I said, why not? And she said, because I cannot give the child what the child deserves, which is a father. So to be chosen father for that child is truly a tremendous gift. It doesn't replace having your own kids, I would say, but it is a very beautiful and life-giving and affirming way to begin or grow a family.
I would add one thing onto that, making sure that you have knowledge of the support groups in your community in regards to infertility support groups and for those women that have suffered through miscarriages, reoccurrent miscarriages, to have knowledge, and if there isn't that support, to help those women find that would be important as well.
Happy to give the last question to you, Diane.
As we get to a close here, I just wanted to thank those of you on the panel and also all of our medical consultants, others are in this room as well, because we as practitioners who work on the front lines with our clients are so grateful to be able to have the resource for your medical and surgical expertise and to know that our patients will be treated with tremendous dignity and respect. So you are all really a gift to us, and you've made our work so much more successful. So it's really a collaborative process. Without what you all offer, and I know you often do that, at least at the beginning, with great sacrifice, I just want you to know how appreciated you are. And then I thought in closing, I wondered if each of you would be able to comment on the scope of your practice in terms of waiting lists, number of clients you've seen, because you are really in demand, I know that. And I'm not sure if the audience would realize what a great investment it is to actually have a nanotechnology medical consultant in their system.
For me, unfortunately, it is quite a length to get in. Being primary care and family medicine, I also do OB with C-sections, so taking call with that, and then being a regional director and over the women's services, I'm kind of pulled in several different directions, and it's difficult. I wish I could make more time in the day, but currently, I think Robin, my fertility care practitioner, said, oh, I couldn't schedule that patient until beginning of December, and which isn't horrible, but for a lot of these women, they're concerned about getting in. So I do a lot of work through her a lot of times in the meantime to help relieve these women of some of the stressors that are going on and try to do as much as I can while they're waiting to see me in that process.
Waitlist is a bad word in our practice. No, it really is a difficult situation because as you know, one physician and an awesome nurse practitioner, Lindsay, who works with me as well, you can only see so many patients in a day. You can only do so many surgeries a week or a month. And because of what I said earlier, is that we're offering a very specialized service that pretty much every woman should want, but maybe they haven't figured it out yet. So there's always going to be, I mean, here in St. Louis we have Dixon, Brennan, Patrick Young, Gosser. I mean, and then those are just the OBGYNs, and then there's other family practice doctors here in St. Louis too. So there's a lot of NAPRO support here. Personally, in our practice, our wait list for a new patient is about 3 months. And then once a patient sees us and we've determined that they need or would best be served by surgery, the wait list for that is another 6 months. So it's not ideal, and it makes me sad to have to say those numbers. And that's why I'm trying to get Mercy to bring another partner on.
there's anybody thinking about starting a practice area, you're going to be busy, which is great, and that's a real blessing. I think our practice right now, it's about 3 months for a new patient, although I'm kind of a pushover, Dr. Butoff, and I'll squish them in there, but that's just because I'm a real pushover. So, but no, about 3 months, about similar to yours, and then I think our surgery is about the same. And now, to give you an idea, last time I checked, I've only been in Houston for 4 years at the Houston Methodist Hospital, and we're already in our reproductive robotic surgery program for all that we do, we're already number 2 in surgical volume for the entire OBGYN, which that's pretty good, and that includes Gen-Onc too. So there's definitely a lot of great value and worth for these practices at institutions, I think.
So I think you're seeing here, and just to make the point clear, that if I think a lot of providers have struggled with, well, if they, do what their heart is telling them or following their conscience, and they try to switch over to a NAPRO type of practice or not prescribe contraception, that they're going to lose patients. And the vast majority of people who have done that switch or made that change, there may be a slight dip initially, but end up being very busy. Again, just from a purely business perspective, you are offering something that most people do not. So you're offering a viable option, and there's a demand for that out there, for whatever the reason, drug-free or just alternative to IVF or whatever. So from a business model, you will be busy. So I specialize in endometriosis. Our commitment is to try to achieve optimal excision, which is to try to basically cut it all out. There are very few centers in the country that do that well, so we have patients come from all over the region and coast to coast, and even some from abroad have come over. So for excision of endo, if that's the primary issue, our waiting list to get in can be 3 to 4 months, and then 8 months for surgery. So that is too long. So we do have a new partner who is just ramping up. He was trained in the same way I am trained, which is he did a fellowship in minimally invasive surgery or laparoscopy, and then did extra training in Atlanta to use the laser to excise. So as he starts to ramp up, hopefully that waiting list will go down. For fertility, we do try to prioritize fertility. So, and we have special office times just for the restorative fertility clinic. So the waiting list to get into the office is not as much as that. It should be 2 to 3 months. And then surgery, we can try to prioritize the surgery within a few months and not be 8 months unless it's stage 4 endo. If it's a stage 4 endo case, those we have to block out a large amount of time. Those are, again, a team effort. We have to incorporate colorectal surgery oftentimes with that. So it can be 8 months regardless for a stage 4 case. But otherwise, if it's not stage 4, then we can try to prioritize those patients for fertility. And if somebody's referred to me, I always tell them, if somebody emails me or somehow notifies me of a patient they're trying to refer into me, we will always try to get them in sooner, especially for fertility. And if we can review the operative notes or the situation, the operative notes from a previous surgery that they've had ahead of time, we can set aside a surgery time even before they're seen.
Thank you very much to our panel.